Now our next talk is on optimization of anti-thrombotic agents in prevention of stroke. So I would like to request Professor Dr. M.B. Padma Srivastava Madam to deliver a talk, and the panelists Dr. Dinesh Khandelwal sir and Dr. R.K. Makkar sir to come on the dais. Dr. Dinesh Khandelwal sir, he is a professor in neurology department, SMS Medical College and Hospital Jaipur, and Dr. R.K. Makkar sir, senior consultant neurology in Saket Hospital, Jaipur. I would request Dr. Suresh Gupta sir to present a bouquet to Padma ma'am. I would request Dr. Yashpal Singh Rathod sir to present a bouquet to chairperson. Dr. Dinesh Khandelwal sir. Thank you sir. Dr. R.K. Makkar sir. Thank you. So now Dr. Dinesh Khandelwal sir and Dr. R.K. Makkar sir, please start the session.
Good morning, everybody. And it is my proud privilege to introduce Professor M.E. Padma. She is my teacher, my mentor as well at AIMS New Delhi. She is professor, head of the Department of Neurology and Chief of Neurosciences, AIMS New Delhi. She was awarded by the prestigious President Award, Padma Shri, and she has very long career at AIMS, and she has worked mainly interest in stroke, but she also has interest in multiple sclerosis and epilepsy. Madam does not need any introduction, and I think there is no conference of a stroke without her, and she has a lot of awards and papers in her publication. I welcome Madam, and I think we should start session. Thank you.
Thank you, Dr. Dinesh. Thank you, chairpersons, and thank you, Eternal Hospital, and specifically to Professor Gupta. And Pranjal, if he's here, he's the reason I'm here. And it's been a great honor and pleasure to share these forenoon with you all. Now I'll come directly to the topic. Now that's Moses who's receiving aspirin from heavens. So we all know that the stroke needs to be prevented. The rate is 8 to 24% of stroke recurrence in the first 5 years. And the vertical on which we build our secondary stroke prevention is antiplatelets. But then we have a whole lot that we don't understand. So these are all these portals wherein you can intervene because aspirin is not preventing 100%. So nothing, no evil is actually prevented 100%, and that's a fact in the universe. But then there are all these aspects where there is an amenable chance to intervene, so that shows up as our potential research and translated to practice. So quintessentially, what are the key questions? That do we still value aspirin as the most valued at particular aging? Then I don't think we bothered about the dose. We all know that most of us use 150 milligrams per day. It can go up and above. Cardiologists love 75 milligrams. No part to them. And we come down to the combos, which are more, of course, more popular. And then are the newer guys much more acceptable and, well, more potentially superior to aspirin. And then we have certain special situations that all of us, patients don't read textbooks and come to us, nor do they find guidelines. So I totally agree with Sri Jitesh, the amazing talk by the way, Sri Jitesh, which I think was more tuned for the World Stroke Organization than here. But then that is true that we need to tweak management according to individual patients. So aspirin, no point. This is like carrying coal to the new castle, and all of us know. And I'm sure a lot of you haven't been even born when this aspirin was established. So we do have definite evidence it works, but it works minimally. And there's a definitive benefit in terms of the balance between the effect as well as the side effect. And so came the clopidogrel has a different mode of action. Remember the first slide? So therefore, they thought that, okay, let's do this angle as well. And true to itself, there have been a lot of trials which have proven that it is slightly more effective than aspirin in preventing the composite vascular outcome events. And then there came these definitive guidelines that what are those situations we use clopidogrel. Yes, again, this is an old story up here that when you have other vascular regions which are involved, especially after a cardiac or a peripheral arterial disease, and then more important to us is in certain clinical situations like a stroke prone state, as well as whenever we have an event while on aspirin. So we come down to our favorite topic, that is combos. So what are the combos that are available to us? We have aspirin clopidogrel, the aspirin diprodamol, the old drug that most of us don't use, aspirin silastazole, ticagrelol, new kid on the block. Then you have the expanded combos, and I definitely want to touch upon a combo of very low dose Novac with aspirin. So the first combination, the match trial came in with a big bang and went out with an even bigger bang. The thing is that when the qualifying event has been a cardiac, most of the outcomes with this combos were great. But when the vascular event, qualifying event was a stroke, and you use this combination much beyond the stroke prone state. For all the youngsters out here, the stroke prone state is a period of about 3 weeks after an acute event. That is where the iron is hot. That is where your ulcerated plaque is bleeding. That is where the wound is raw. So it is no rocket science to understand that you give it time, the wound heals, right? So it is when there is a stroke prone state, when there's a maximum risk of a recurrence of stroke, irrespective of what subtype you're dealing with, that is where you hit it hard. You give your combos, you do your interventions, but once the wound is healed, then the flip side of the safety factor kicks in. And that's what happened to Match. So there were more bleeds, it went out. Then we have the SPSC, which is even more a no-brainer trial, in the sense they again have taken a combo beyond the stroke prone state. This qualifying event could have been 3 months before. So it was again a negative trial, because remember, when you are really using more than one drug, then you're upping the risk of a bleed when you don't need that much. But you need that when you have to tackle that stroke prone state. So the CADIS trial on the other side, when you're looking for a stroke prevention, all of you know that in a discharge plan, you need to have a subtype of an ischemic event. Before, when you put in your prophylaxis, you need to know it is a Lacoon small vessel, it's a large vessel, it's a cardioembolic, or something else. And forget about ESIS, that construct is just fading away. So therefore, when you need a subtype, then you get your prophylactic regimen in place. Do I treat my AF with an aspirin? Then I prevent 20%, isn't it? So therefore, a subtype was important, and in a subtype of a large vessel stroke, and then when they used this combination, and they looked at a biomarker of an outcome in the form of doing a transcranial Doppler and looking at the microembolic signals of the hips, it was better controlled with a combination. So that gave you the impetus that yes, you can't have a one glove approach. You need to actually individualize when you get your prophylaxis. Similar results in Charisma, largely a negative trial, again using this combo. And then came Chance from China, which changed our mindset or the trajectory of how we thought that we need to prevent another stroke happening. So here the target was a stroke prone state. Here the target was the first 3 weeks. So when in the first 3 weeks of a mild to moderate, playing it safe, I don't want a large artery with everything there infarcted and all the vessels which are degenerated, the walls bleeding, so they didn't want a hemorrhage, so they chose. Most of the trials, and Srijish will agree with me, you play safe when you go on to your phase 2 and phase 3. So therefore, in the chance trial, it was definitely positive when you used a combo in the first 21 days, and that sort of launched this concept well laid out that in a stroke prone state, you use a combo. The combination, the evidence was aspirin and clopidogrel, and then go on to your individual drug. You want to give clopidogrel or you want to give aspirin. Similar thing got pointed out in the point trial, which used another genetic population. Every time there is race and ethnicity, so chances Chinese, so let's get the Caucasians, and so the similar thing was involved. The minor differences between these two trials, and I'm not getting into detail, you'll all get very bored with that. So the take-home message is in the stroke-prone state, use a combination for the first 3 weeks. Forget about these statistics. There was someone who said there are lies and there are damn lies and then there are statistics. I'm not too concerned about it. So when you do a meta-analysis of all these trials, and that's another statistical thing in epidemiology, so you definitely have a benefit up till 21 days and unlikely to have that the safety net of a risk versus benefit beyond that. So we're all using it. Yes, so we are all using this combination. It's in practice. The second combination, aspirin diphenol, in fact, this came much beyond the aspirin clopidogrel. Even the cardiologists were using it. We have a tendency to follow the cardiologists. I mean, a couple of cardiologists here, they're very happy following you all. But anyhow, they do set the trend. So this aspirin diphenol was, in fact, the combination which got approval much beyond aspirin clopidogrel based on 2 major trials. But we all have practical difficulties. One, you can't start off straight away. Aspirin low dose and extended release diphenol. So 25 plus 200 given twice a day. You start off twice a day, they'll all come back with you with big back headaches. So it was a process. You start with one and then you give something else and then you build it up. Forget it. So in essence, most of us are not using this, though this is well within the guidelines. Nobody will sue you if you have this, but this again is in the stroke-prone state. So remember, this is another combination which is available with you, but somehow it has not taken off the way aspirin clopidogrel has done. And I think we have a cardiology colleagues to thank or blame for, because aspirin clopidogrel is a preferred thing for the cardiologist. Profess was designed as a win-win trial, which really didn't turn out. They thought that we have an approved aspirin diphenol and let's try it out with clopidogrel. Largely, the benefit was equal. So in terms of efficacy, it seems this combination is not great as compared to single antiplatelet clopidogrel. Then we have aspirin silastazole. Believe me, ladies and gentlemen, this is a very useful combination. The thing with silastazole is the mode of action is different. We have a third angle which has come in, which is a distant cousin of dipridamol, probably much more effective. And all these trials have been from the Far East. So you have the Chinese and the Koreans who have actually taken up this molecule. We've got approval of silastazole for peripheral arterial disease, and I use this combination when I'm up against the wall. In terms of having the bleed, every time you give an aspirin, they have hematuria. You give clopidogrel, they'll have hematuria. What do I do? So in such cases, I found silastazole pretty much, it's kind of my rescue drug. So it's not there up in terms of guidelines, but I think most of these trials have said that it is non-inferior to aspirin and has much less hemorrhagic potential compared to aspirin. As practice clinicians, that's what we need. We need a little bit of safety. We need efficacy. It's as good as aspirin. It doesn't cause bleed like aspirin. Good for me. So there has been this, a largely Japanese and a high-risk, not cardiovascular trial, which has been done, and it is continued for half a year longer now, 3.5 years. And largely, again, it seems to be that the dual therapy, with aspirin, silastazole also didn't have so much of bleed. The take home here is that aspirin, silastazole, which is aspirin low dose 75 and silastazole 100 BD. Fair enough, you can do that. Okay, so have that as a rescue drug. The other one is aspirin ticagrelor. That's a new kid on the block. We were part of the Thales trial as well, contributed precious 4 patients into this mammoth size trial. Now, ticagrelor is again has come in with a big bang in the sense that they're using ticagrelor right, left, and center, especially after an acute coronary event and as well as after acute coronary intervention by the cardiologist. Brilinta has been there on board, 90 milligrams PD. All of you are aware of that. But then when they went on to the Socrates trial, which was the first trial which looked into the similar kind in stroke, and here it was an acute stroke in the sense they did not go into much beyond the stroke prone state. Didn't really carry it off because you had more bleeds. Largely, it had more bleeds. Then they looked into it again, and they looked into a small cohort of the Socrates trial where it was largely large artery. So if you had a significant atherosclerotic process involving the arch or the carotid artery and looked into that subgroup and looked at giving this combination very early after a stroke and for the first 3 weeks. So again, a stroke prone state, but a cohort of a large artery disease. And in that was how you had the, Prince trial. I'm not getting into it. So these are the, I don't like this small letter stuff. I'm sorry about it. So the Thales trial, which was essentially the trial which looked into this cohort, published. Then this has definitely some limitations, definitely had bleeds, but then the incidence of stroke definitely was much less. In the recurrence of an ischemic event was less in the combo of aspirin and ticagrelor. That's a take home. And the bleed which has occurred did not change the outcome for the worse in the combination arm. We don't have long-term data beyond 30 days. So again, you're limiting yourself to the first 1 month. So can we rely on the Thales data for the real-world experience of using ticagrelor? New kit. There is a 90 milligrams morning-evening dose along with aspirin. Maybe, but to me, the biggest importance in the Thales trial is that those who have a resistance to clopidogrel, this drug will come on. So please understand that when you're having a recurrence of stroke, you've done everything. You've taken care of the stent, you've actually taken care of whatever the atrophy, you told them to stop smoking, and you're taking care of blood pressure, diabetes, continues to have events. Believe me, you will have such patients. And then when you're looking for resistance and you prove that there is and you can do this clopidogrel resistance by a blood test now, it's freely available. You get it, then you can shift to ticagrelor in that situation. But again, remember, it is a stroke prone state, so they have a recurrence. You look for clopidogrel resistance, you found it. Then in the first 1 month, get this combination. So that is where your practice point will be the usage of ticagrelor and who have it in your market right now. Okay, so in the reanalysis, they found that the benefit endpoint and the risk endpoint again tilts towards the benefit with ticagrelor. They've looked at everything. They looked at gastro-severe bleeding. They looked at that means the systemic as well as intracranial bleeds. The safety factor was using this combination in the first 1 month. Okay, so the ischemic event was much more nicely controlled as compared to major bleed. And picturesque depiction and visually impactful, and there you have it. So I'm not getting into subgroup analysis, and this is that blessed shift analysis and lots of he showed the forest plot with the shift analysis. Those blocks actually represent that everything which is white is basically good, and everything dark is bad. Now and then there is this compare and contrast between different antiplatelets, and including all strokes and all cause mortality. And this was a great, again, people, what they do is, the hard work is done by a lot of other people, and then there are these extremely brilliant group of people who sit and do all this analysis and call it meta-analysis, and then they get published in Lancet and in NEJM. And I hope you know the latest impact factors of Lancet. It is something what Dheeraj, it's shot up to more than 220. It's overshot NEJM. And NEJM itself is 200 thanks to COVID. It'll all fall down. So then we have, so in this, again, they said that all these antiplatelets are great. Okay, so up there you have all strokes, you have silastazole, and then everything which is, cutting the midline is obviously not. So I didn't even know there was something called aspirin sulfenpyrazole. Probably was there even before I was born, and I'm a grandmother. So therefore, those things are forget it. So the ones which are beneficial are you have silastazole, you have clopidogrel aspirin, you have clopidogrel alone, you have ticagrelor aspirin, diphenol aspirin, ticagrelor alone. Cyclopidine is a dead drug. Don't even think about it. And then you have the bands or the ones which are more shifting towards, the other varieties which we are not talking about. There's no evidence on. Okay. So in your basket of arsenal or armamentarium to prevent a secondary ischemic event, you have a large number to choose with. It's exciting, essentially. And that holds true for whether it's ischemic, stroke, cardiovascular event, and for a hemorrhagic bleed. Down there, you have the cyclopidine aspirin, idiotic. But look at everything. There's only one drug which probably is okay, and that is some Barapaxar, and it has not been proven to be beneficial. So otherwise, every single drug has a bleed risk, and you have to weigh out the risk and benefit ratio. So I'm going to skip all these things which you will get bored with. Now we come to this great combination. They thought, well, we can combine, and we have different focus. So now we can combine aspirin, clopidogrel, diphenol. So this trial came in, the TARDIS trial, it also fell flat because that was going a little way too much. So there's only this much that the brain can tolerate your intervention. There were more severe bleeding. So when you're going beyond the current antiplatelets that you have, please don't combine three. If you have to go to the third one of them is resistant and you get beyond it. Now we come to the stroke subtype, and I'm looking at ICAD. Now we are dealing with ICAD, ladies and gentlemen. ICAD is real, it's happening, it's here to stay. And all of us have this tendency. The Asian population, Indian population have a very peculiar variety or a spread of atherosclerotic process in the brain. You have both intra and extracranial. You're not like our Far East colleagues where we hardly have extracranial. We have both. And this was actually first published by Professor Subhash Kaul from the southern part. That's a cohort they studied, and they published this. But we have a very peculiar distribution. So in our ICAD patients, of course, we have the trigger happy interventionalist, and there is a role for intervention. But this is a place where probably you need to spread out your combinations beyond the first 21 days. So the current guideline for an intracranial arterial or intracranial, I should say arterial, ICAD is atherosclerotic disease. In such situations, we give for 3 months. But we now have an ongoing trial with Nilkasa Medical Research. Dheeraj is part of that. In that, we're going to test out for 1 whole year. Because we believe that in this subgroup of patients, we need to have this extremely aggressive intervention in terms of a medical management versus you have an intervention arm. Because in an intervention arm, if I have Atulabh here with me, I will happily give all my patients. But the problem with intervention is that similar to expertise, it is not uniform. And one of Socrates trials will end, if you remember Atulabh, the line was, till you have safe landing procedures, you need to be cautious. But I believe you do have safe landing procedures. So there is a role for intervention in certain subgroup of patients. But till then, at this point of time, your combo for 3 months, when you document ICAD. Okay, and that's what the Socrates trial was all about, in which they said that the medical management is probably beneficial, but that was then. It probably doesn't apply now. But here we do have a combo for a longer period of time. So the recommendations are up there. You can look them up. You have whatever guidelines, and we have, in fact, we are bringing out our Indian stroke guidelines, which for some reason is still sitting with the DGHS office in the Ministry of Health. It's been formulated, ready to ship. I think they are just waiting for some time to publish it. That is 2022. Update updated guidelines of the Indian stroke guidelines. So this is a nice meta-analysis published in the British Medical Journal by Professor Prasad, my teacher. And in that, you do have that where you will have a duet versus single, and they've sort of dissected out the exact timelines. And the crux of this, again, meta-analysis is that they've broken down to numbers. And when you talk of numbers, it's always used to explain to the non-medical person, especially the policymakers and implementers. And they've really done that. Everything in pink being good and, blue in bad. And they've actually turned out this. It's a great slide to have it, that you can have this. I will leave the slides out here. So that is the duration anyway. We stay with 21 days. Then when a person comes to you, as I told before, he's not going to read textbooks and comes to you. So each individual is unique as its own fingerprint. So there is an SM stroke risk. This is again not a new one. It's been there. But somehow this applies to me in my clinical practice than all these guidelines which have come. Because there could be a person who is 80, lovely 94 years who are winning gold. So age is just a number, isn't it? The shooter Dadi is 94 years old. So you have age out there, hypertension, diabetes, cardiac disease, peripheral artery disease, one who smokes, continues to smoke like a chimney, and then you have additional, previous history of strokes and PIAs. You add up these risk factors. So there could be someone who's 72 years old, hypertensive, had a TIA. So what is the risk there? Probably 2. And then you have this, right? You have even a 65-year-old who continues to live life to its fullest and not take care of vascular risk factors and had outcomes. His risk could be 6. Now, will you have the same approach in controlling the secondary stroke? I don't think so. So therefore, this has been a published figure wherein you can use a single antiplatelet, which is in purple, and the blue is double. And you look when the annual event rate, if the person is on a single antiplatelet, is triple the times than giving a double antiplatelet. So therefore, please look at your individual thing. So the recommendations, therefore, are that you may need to do combinations, which is superior to monotherapy in situations which is in stroke-prone state. It's not just that, especially in those individuals who have a number of risk factors. Antiplatelet resistance is here. In fact, the documented resistance in Indian subcontinent is varying, and we're getting more literature because of a lot of genetic studies. There are ongoing studies even in my hospital. So you have something between 25% and reported even up to 40%. I think 40% is way too high, but I think 1/4 of our patients would have resistance to accident catheter. Roughly, it could be much higher also. So therefore, they would have failures. But before you say somebody is resistant, you definitely look into the compliance. You definitely have to look into the risk factor control. Uncontrolled diabetes of HbA1c of 12, and you expect the poor little aspirin to do the trick, is not going to do that. And also his own lifestyle. And I know people who've done everything. They actually go to a gym every day, and they will take a lift to climb up 2 stairs, and then they do the gymming. They take the lift, come down, and they take their car to travel 1 kilometer to their house. It is the attitude. So therefore, you will have to look at a holistic human being attitude to prevent another vascular event. It's just not a drug. Plus your co-intervention, including of course PPIs and various other things and how they're interacting. Look at all of them and then come down to your resistance before you write the drug off. So you have to address all these things. I don't know about entry versus non-entry quoted, but that continues to stay on board there. Yes, you can increase your antiplatelet dose. A lot of cardiologists start with 75, they love 75, they stay at 75. So when they come there, you can always up it to 150. Add another antiplatelet, and that's where you have other drugs come in. But then please remember, there are situations we have really driven up the wall. As I said before, you give a little dose and they start having hematuria. It's the commonest. And you go to the urologist, they do everything possible, you can't find the source. The moment you give antiplatelet, they'll bleed. And they have a posterior circulation. We've lost patients that way. And there's nothing, no intervention otherwise is needed. So in such situations, you have silastazole coming in there. And the unique clinical situations, of course, you have a carotid artery stenosis combo, and please intervene and get your revascularization done. Whether it's angioplasty, stenting, or endarterectomy, I'm going to leave it up there. That's another debate by itself. So in a carotid artery dissection, will you do something? There are situations you will, but largely probably no. You probably single antiplatelet will do the trick. And pregnancy and peripartum, you will keep encountering this. What do you do in the first trimester? What do you do in the last trimester? But in the middle, it's fine. You can continue what you can. In the first trimester, the problems with antiplatelets. And a lot of times you just shift to unfractionated heparin. Most of these high-risk cases would be admitted or closely monitored. So we can do this. We've done in patients with rheumatic heart disease, who were on anticoagulants, we shift them. You can give in the second trimester, go back to your oral drug. But again, in the last trimester, go back to the safest seems to be unfractionated. Perioperative period largely depends upon my surgeons. I've had surgeons who on double antiplatelets would go on happily intervene, and there are some neurosurgeons, I don't know about neurosurgeons here, pardon me, but there are some neurosurgeons who you stop that aspirin, I will intervene after a week. Isn't that so, Dheeraj? So you depends on the spectrum of the surgeons that you have. So we do not know about it. Depends upon how brave they are, but 48 hours per week. But whenever someone comes and says, I need to have my tooth pulled out, and my dentist has said to you that you will have to stop aspirin, I tell them, please change your dentist, right? Because the guidelines have moved eons of miles away. If they're not abreast with the guideline, change them. After ICH, now we know. I put the slide up because we don't have a definitive guideline, but now we know. After an ICH, which is mild, probably will wait for 4 weeks. And I'm going to get it on board. And largely the consensus 6 months because it's the same patient. They have hypertension, diabetes, they also have heart attacks. And you'll have largely silent ischemia happening in that, and then I have a heart attack tomorrow. Why can't I put those things, back on board? I could never really understand why the guidelines are not up there. And the worst is being between devil and deep sea. I have a prosthetic valve on anticoagulant. They have a bleed, and the prosthetic valve is struck, and they're having an atrial fibrillation, and there's a bleed in the cerebellum. How do you deal with it? It's individual. There are people where I've done CT every single day. The moment there was no hydrocephalus beyond 72 hours and the cerebellar bleed was coming down in the CCU, I restarted anticoagulant. Believe me, it's a tightrope walk. Sometimes you're faced with these situations. Stroke, ladies and gentlemen, is not armchair neurology. You need to have the aptitude and attitude to get at 2 o'clock in the morning and go and take that call, which is extremely important between life and death. You're up to it, you do the stroke medicine. So you'll keep getting these situations, but there is a way forward. So largely the last slide up here is never ever give up on your stroke patient. There's so much happening, so much to happen. Be aggressive. There has been a tectonic shift in the way you approach a stroke patient in whether it's an acute or in prevention of another stroke happening. There's so much out there. So please don't ever give up on your stroke patient. Thanks.
Thanks, ma'am, Dr. MVP Srivastava, for elucidating her talk brilliantly. So nice. Thanks.
Thank you, ma'am, for a nice, wonderful lecture. I would request Dr. Dinesh Khandelwal sir and Dr. Matkar sir to present a memorandum to Padma ma'am. Thank you, sir. Thank you, Dinesh sir. Thank you. So